Hello friends, good evening. Welcome back to Unacademy. Let's crack NEET PG. I'm Dr. Shonali Chandra, and today I've chosen a very important topic for revision via way of MCQs, and I'll be discussing questions on preeclampsia and eclampsia. I have highlighted my reference code here, that is SHONALI. So if you take the subscription from the Unacademy platform, you can use this code to avail a 10% discount on your subscription package. Unacademy is India's largest learning platform. The advantage of taking a plus subscription is that it will give you access to unlimited live and recorded courses from India's best educators. You'll get daily live classes. The courses are structured keeping in line with the latest NEET PG syllabus. There are also live tests and quizzes which will help you evaluate your performance as you go along. And most importantly, one subscription is giving unlimited access. So you can watch all the live sessions from all the faculties who are active on the platform. And even if you miss out on the live sessions, you can always go back and watch the recorded versions from the comfort of your own devices. Top educators are associated with the platform. All 19 subjects that we need to prepare for our post-grad entrance examination, they are covered. Every now and then, comprehensive batch courses and short duration crash courses, they keep getting launched. So you can check out the ongoing courses in the platform as well. As far as the subscription packages go, you can choose one depending on your need and requirements. So if you're targeting the upcoming exam, you can take the short duration 3 months crash course. So you can take the 3-month subscription. If you're targeting the next exam, then you can take the 12-month subscription. It turns out to be more economical in the longer run. It will give you ample time to go through all of the sessions and will leave you enough time in the end to revise. And for those of you who are targeting the, you are still in your third year or final year MBBS and want a slower pace of preparation, you can take the 24-month subscription. It turns out to be more economical in the longer run. And if you subscribe using my code, that is SHONALI, then you can avail a 10% discount on your subscription package, whatever you choose from. You can find me on the free live classes also. These are special classes which are taken on the Unacademy platform. So you can check them out on the platform as well. So now coming back to the session at hand for today, where we are going to deal with questions on the topic pertaining to preeclampsia and eclampsia, a very important clinical situation in obstetrics, which has far-reaching consequences for both the mother and the baby. So yes, it's a very important topic for our post-grad entrance examination. It is a very important topic for people who are practicing obstetrics in clinics. It's a very important topic also for your final year MBBS examinations. So good evening, Neo, Manisha, Gemechu, I hope I am pronouncing your name correctly. Pardon me if I'm not. And Richa Patel, good evening, everybody who has joined in. Right? So let us begin without wasting any further time. And let's have a look at the first question of the day. Janvi, good evening. Very good evening to you. So we've just started the session. We're taking the first question of the day. So let's have a look. There's a 28-year-old primary Gravida, and she is at 39 weeks and she is in early labor. The CTG, the cardiotocography, is reactive on admission, so the baby is doing well. Her nurse steps out for a moment, okay, and returns to find her having a seizure. The nurse administers a bolus dose of magnesium sulfate, so that's a good nurse that we have there. The seizure stops. The CTG shows absent baseline variability, but there are no decelerations, and the baseline is static at 130 beats per minute. So something acute happened. The woman suddenly had a seizure. The baseline variability of the CTG became absent. The baseline is otherwise maintained. There are no decelerations. What would your next therapy be aimed at? So what are you going to do immediately after this event? The nurse has called you. You've reached there on the spot. Do you give diuretics to reduce pedal edema? Do you give antihypertensives till the BP is less than 110/70? Do you prepare for immediate cesarean delivery by cesarean section, or you keep the patient free of convulsions, coma, and acidosis? What would your next therapy be primarily be aimed at after reaching on the spot in this current situation? So analyze yourself, think that you are there, think that there's a primary gravida who's in early labor, CTG so far had been reactive, nurse went out for a moment, came back, there's a seizure, she's done what she could, she's given the first bolus dose of magnesium sulfate, right? The seizure has itself stopped. There is a transient there, there's some problem in the baseline variability there. What would your next therapy be aimed at? Now see, I can understand, very good, very good. You are saying that you would prepare for immediate delivery by cesarean section. I would like to differ there for a while. And I would justify my answer also. So we agree that there is no reason to give diuretics to treat pedal edema. Diuretics in the case of eclampsia. This is eclampsia, isn't it? This is eclampsia. A woman in early labor, she has thrown a convulsion. Okay, the BP reading is not given to us, but any seizure which happens around the time of delivery or in an antepartum patient or an immediate postpartum woman, right? Pregnancy and seizure is eclampsia until it is proven to be otherwise. So we are sure of that this particular condition is eclampsia. Right? And I'm getting a difference of opinion. Dr. Musarrat retracted the message, but you said keeping the patient free of convulsions, coma, and acidosis would be a prime concern. So let's see here. Woman has eclampsia, all right? And the important thing here to note is that there are baseline variabilities absent for a while, but there are no decelerations, right? The baseline itself is also 130 per minute. Right? So this is revising two topics on the other hand. And in clinical situations, obviously, you have to take care into consideration of multiple topics. You'll have to think together. Right? So reducing pedal edema with diuretics is not my main concern here. Diuretics are given to treat pulmonary edema in a case of eclampsia. So nowhere it is mentioning that there's pulmonary edema. I will give antihypertensives for sure if the BP is high. But my goal to control BP is not to make it too less. I will not like to control it to such low levels as to make it 110/70, because that would decrease placental perfusion. Right? So the placenta is getting perfused with blood because of blood pressure, isn't it? Right? So in a case of preeclampsia or eclampsia, anyways, the spiral arterioles are narrow. The spiral arterioles which are taking blood from the maternal side to the placenta, which are infusing the placenta with maternal blood, those spiral arterioles are already narrow. So I don't want to end up doing placental hypoperfusion. Okay, I don't want the placenta to get hypoperfused. All right, so I want the forward flow in the placenta to be maintained, and for that reason, yes, I would like to control the BP, but I would not like to make it less than 110/70. I'm happy with the BP between 130 to 140 systolic and somewhere between 80 to 90 diastolic. That is good enough, right? Now the doubt is whether to prepare for immediate delivery by cesarean section or whether to keep the patient free of convulsions, coma, and acidosis. Now, why would I not like to go for an immediate cesarean section? Because only one criteria is abnormal. The only thing that is abnormal in the CTG trace is absent baseline variability. During the act of the convulsion, when the convulsions happen, transient fetal heart rate deceleration, transient fetal heart rate drop, and transient baseline variability can be seen. It will get corrected as the convulsion will pass off and as the woman will recover from that. So there is no urgent need for delivery by cesarean section. Only one criteria is abnormal. There's absent baseline variability, right? So during the episode of convulsion, what happens is for a transient moment of time, blood flow through the placenta is decreased, but that will improve once the woman's convulsion convulsion passes off and some time passes off. So I can still wait and watch before jumping ahead with cesarean section. But my prime concern right now, my prime concern would be to keep the woman free from convulsions, coma, and acidosis, right? How am I going to do that? I'm going to place the resuscitation primary. Okay, I'm going to go for primarily resuscitation, maintaining the airway, the circulation, the breathing of the woman, the ABCs. Do not forget that the woman just had a convulsion. I would like to ensure that the correct bolus of magnesium sulfate has been given, that magnesium sulfate infusion is started and maintenance dose is continued. I will ensure that the blood investigations have been sent. I will ensure that she doesn't go into an acidotic state. So maintaining the woman's well-being is the priority here. That is why my prime concern would be to keep the patient free of convulsions, coma, and acidosis. And Dr. Musarrat is rightly saying that once I've done the primary treatment, I can even induce the woman. I will in fact induce the woman and terminate the pregnancy and try for a vaginal delivery and not directly jump for cesarean section. All right? Clear on that? So that's why I'm not choosing option C as an answer here. So when landed in such situations, let's not jump the gun and do a cesarean section immediately. Focus on the woman first. Stabilize the woman first. That is your prime concern. All right. Now let's move ahead and see the next question. Which of the following would be the most common warning sign of her condition? Her condition is eclampsia. Which of the following would be the most common warning sign of her condition? Degree of proteinuria, severe throbbing headache, facial edema, or a blood pressure more than 170 by 120? Right? Had you been the person who was taking care of this woman in the labor room, which of these things, which of these four options would have triggered you to think that eclampsia or a convulsion is imminent or can happen anytime? This is what they're asking you. And very good, all of you, rightly saying, everybody's rightly answering. Manisha, Musarrat, Neo, Tabish, and that severe throbbing headache would be the most common and most important impending signs of impending eclampsia. If a woman is hypertensive and she complains of severe throbbing headache, or she complains of blurring of vision, these are signs of impending eclampsia. These are the most important warning signs that we should be cautious about. So while taking care of women in your wards who are eclampsia, who are under monitoring, or who are laboring, women with eclampsia, make it a point that you ask her, is she having headache? Is she complaining of blurring of vision? And do not ignore these warning signs. These are very, very important. Now, the degree of proteinuria, yes, of course, if the proteinuria is severe, it is severe preeclampsia. But yes, there are women who have severe proteinuria, more than 5 plus, 3 plus, 4 plus proteinuria and dipstick, and they never go on to develop seizure, right? So there are patients like that. There are women who have just 1 plus proteinuria, just 2 plus proteinuria, mild degrees of proteinuria, yet they have convulsions. Facial edema is not significant for anything of that sort. Now, blood pressure, which is more than 170 by 120. Now, such high blood pressure, yes, such high blood pressure can accompany eclampsia and the seizure. But there are women, and there are about 10 to 15% of cases where women with normal BPs have also gone into convulsions. There are cases where women with such high BPs have not gone into convulsions. What is the importance of such severe acute hypertension? Such severe acute hypertension will place the woman at risk of an intracerebral bleed. Such severe hypertension is going to place the woman at risk of stroke. That is more likely with such high BP. But the most common warning sign of her condition or eclampsia is going to be severe throbbing headache. This severe throbbing headache, this blurring of vision happens because during the state of severe preeclampsia and impending eclampsia, there is this cerebral edema. There is this massive cerebral hyperperfusion which has a predilection for the occipital lobes. And that's why the woman complains of this throbbing headache, which is more located towards the occipital lobe, and blurring of vision also results because of that reason. All right. Now, you are asking which symptom or sign would be the first to appear in preeclampsia. Now, preeclampsia is a constellation of signs and symptoms, right? So, preeclampsia is always identified with a high BP to begin with. There is high BP beyond 20 weeks of gestation. There, you would identify preeclampsia. After that, obviously, there are other signs which are there going to accompany preeclampsia. Everything, all systems in the body, it's a multi-system organ involvement. There's going to be pedal edema, there is going to be a thrombocytopenia, there can be pulmonary edema, the kidneys are affected, there can be increased serum creatinine. So there are many findings which accompany this preeclampsia condition. Primarily, the identification will first begin with picking up high BP during pregnancy beyond 20 weeks of gestation. All right, so that would be the first thing that would happen. After that, depending upon the severity of preeclampsia, depending upon which organ systems are involved, a constellation of signs and symptoms can appear. All right, now let's have a look at the next question. Let's have a look at this next question. Now, the longer the woman stays in the state of eclampsia, they're making a statement here which is correct. I'll vouch for the statement. The longer the woman stays in the state of eclampsia, more is the risk of maternal morbidity and morbidity. Okay, morbidity and mortality. Right. So, the eclampsia is a state where there has been cerebral edema. Eclampsia is a state where there has been cerebral edema. There are areas of cerebral hyperperfusion. There are areas of cerebral hyperperfusion and hypoperfusion. Okay, this edema has made, and these areas of hyperperfusion and hypoperfusion all has predisposed to cerebral anoxia, and that has triggered the convulsion. Right? Now, as long as the cerebral edema, the cerebral hyperperfusion is going to persist, the woman's condition is not going to improve. The woman's condition is going to improve once the source of the problem in a case of preeclampsia and eclampsia is the placenta. Is the chorionic villi of the placenta, which are releasing the inflammatory mediators. It is these inflammatory mediators which are causing all the problems. It is these inflammatory mediators which are causing endothelial damage in the entire systemic circulation. They are causing endothelial damage at the level of the placental circulation. They are causing endothelial damage at the level of the pulmonary circulation. The kidneys are affected because of that endothelial damage, right? The liver function is deteriorating, right? The cerebral edema that is happening, it is all because of these inflammatory mediators. If these inflammatory mediators are not removed from the circulation, the source is the placenta, the condition does not improve. So the ultimate definitive treatment for preeclampsia or eclampsia is going to be delivery, because it is when the delivery of the mother will take place, that is when the placenta will be out of the body. Right? So I've had a detailed discussion on the pathophysiology of preeclampsia and eclampsia in YouTube, and if some people were there with me earlier, some of you were not there with me earlier. So those of you who have not seen it, please go ahead and see it. Right? That will help clear a lot of doubts. What I'm coming to here is that the state of eclampsia puts the mother's life at risk. Right? And the longer that the delivery is delayed, the more is the risk. The woman is most at risk for mortality from which of the following conditions? Sepsis, uremia, congestive heart failure, or cerebral hemorrhage. She could have uremia, I agree, with renal involvement. She could have congestive heart failure also, I agree. She could have sepsis also. But what would be the most important condition which puts the woman at risk of dying? The woman is most at risk for dying or mortality from which of the following conditions? I've already got the answer from Richa, Musarrat, Pragya, and Shataj Alam and Subhash. It's cerebral hemorrhage. Very good. So cerebral hemorrhage is the most important cause and the most common cause and the most risky cause, most risk for the woman to die, or mortality is increased significantly with cerebral hemorrhage, right? So stroke can kill the woman immediately, right? So sudden risk of dying increases if there is cerebral hemorrhage, right? Now let's have a look at the next question. Women with eclampsia and preeclampsia, when compared to normal pregnant women, will have a decrease in which of the following? Will have a decrease in which of the following? Plasma volume, uric acid, liver enzymes, and serum creatinine. If you compare women suffering from preeclampsia, eclampsia to that with normal pregnant women, which of the following factors will decrease in the woman? Let's see. Plasma volume, uric acid, liver enzymes, or serum creatinine. What will decrease? So Manisha, quickest to answer. Neo following behind. Everybody is answering yes. Plasma volume decreases. Very, very important. Very, very important. So this endothelial damage which happens in the various systemic circulations of the body in a woman, right? What do they do? If this is the blood vessel and that's your endothelium, and that's your endothelium that has been rendered all damaged and inflamed, what will happen? We will have leaky capillaries. When the capillaries are leaky, fluid leaks out. Fluid leaks out. Normally, in normal pregnant women, plasma volume increases, blood volume increases, right? Isn't it? There is hemodilution. There is hemodilution. But women suffering from eclampsia and preeclampsia, they are not able to undergo hemodilution as normal pregnant women should, and their plasma volume remains contracted. There is hemoconcentration. There is hemoconcentration, and they are not able to increase their plasma volume as normal pregnant women should. So plasma volume is not increasing as expected. It is going to be contracted, whereas the uric acid levels are going to increase, the liver enzymes are going to increase, and the serum creatinine levels are also going to increase in women suffering from eclampsia and pre-eclampsia. Very good, extremely good. Now let's see another very, very important point that I want to make here, and which I need you to remember as far as pre-eclampsia and eclampsia is considered, that whenever there is hemoconcentration, imagine this is the blood volume of the woman suffering from eclampsia, preeclampsia, and she is hemoconcentrated. And there's another blood volume of a normal pregnant woman who has undergone hemodilution, right? Now, if I were to take 500 ml of blood from both the systems, if I were to take 500 ml of blood from both the systems, who is losing more RBCs? Who is losing more RBCs? Woman with preeclampsia, eclampsia, or a normal woman? This hemodilution is very, very important in pregnancy because it prevents against blood loss. Not that it prevents against blood loss per se, but indirectly. Because if a 500 ml of blood is lost in a normal pregnant woman, then more of plasma is lost and less of RBCs are lost. But a woman who is hemoconcentrated, whose plasma volume is contracted, she is having eclampsia, preeclampsia, she will not be able to tolerate this 500 ml blood loss. She is going to lose more RBCs. So be wary of blood loss in women who are having preeclampsia, eclampsia. They will not be able to tolerate even little amount of blood loss. To add to that, if they are anemic, it even compounds the problem even further. Anemia, preeclampsia, eclampsia, deadly combination. These women are not going to be able to tolerate blood loss at all. They are very sensitive to small amounts of blood loss as well. So keep that in mind, important point, right? Now let's have a look at the next question. There's a 19-year-old unbooked primary gravida. She comes to the emergency at term with complaint of severe headache for 2 days. Her pulse rate is 90 per minute. BP is 150 by 90 mmHg. While being examined, she had a convulsion. You have ordered the nurse to give the loading dose of magnesium sulfate. What is your course of action in the meanwhile? Urgent ultrasound to rule out molar pregnancy. Prepare for emergency cesarean section. Protect the patient airway or give IV labetalol. I've already discussed this, guys. I want a correct answer. I'm sure all of you can come to the right answer here. There's a 19-year-old unbooked primary gravida. She's not had any prenatal visit so far. She comes with the complaint of severe headache. You were on your way to examine her. You checked the pulse rate, BP. She had a convulsion. You quickly ordered the nurse to give magnesium sulfate loading dose. She's prepping it up. She's coming with the injection. Meanwhile, what do? Protect the patient airway. Protect the patient airway. That is very, very important. She is having a convulsion right in front of you. Even if she is not a pregnant person, it could be a man, it could be a woman, it could be anybody. Anybody who's having a convulsion in front of you, your prime concern has to protect the person's airway, because during that convulsion, during that act of convulsion, what can happen? Aspiration pneumonitis can take place. So these are some basic steps which are involved in managing a convulsion. Put the patient's head to one side, right? Put in a Goodell's airway so that the airway is maintained, right? Make sure that this pulmonary aspiration does not take place. Woman can aspirate the contents in the gastric contents can be aspirated into the lungs and can lead to a whole new set of complications, right? So maintaining the patient airway when a patient is having a convulsion right in front of you is of is of prime importance. Once you do that, once you manage the immediate convulsion, right, and ensure that you've stabilized the woman, after that, then you'll do ultrasound, then you'll start making a decision as to what to do, whether to terminate the pregnancy, how to terminate the pregnancy. Is a cesarean required or not required? Can we go insist on a vaginal delivery? Can we go for induction of labor? Right? And injection labetalol to control the BP will be required, but when there is an acute hypertensive crisis, right? Here the BP is 150 by 90, so we don't need to give IV labetalol right now, right? So very, very good. Subhash rightly said that after ABC, then we go for anti-hypertensives depending upon the BP. So you'll have to guide your management of BP management of hypertension according to the BP. Magnesium sulfate, she's had a convulsion, loading dose has been given, further magnesium sulfate will be continued. You don't just stop at the loading dose. You have to continue. Once the loading dose has been given, it has to be continued. Okay? Now let's see the next question. Loading dose of magnesium sulfate is given, right? We're talking about the same woman. This 19-year-old unbooked gravida whom you were examining. Loading dose of magnesium sulfate is given. Meanwhile, she awakens from her seizure and in her postictal phase, she starts complaining of blurring of vision. What is the most likely finding on fundoscopic examination? What is the most likely finding on fundoscopic examination? Yes, she complains of blurring of vision. What is the most likely finding on fundoscopic examination? If you were to look at the fundus of the woman, if you were to call your ophthalmology colleagues and ask them to examine the fundus of this woman who is having eclampsia, what is your most likely finding going to be? Retinal detachment. If retinal detachment occurs, that means she would go blind. Many women who complain of blurring of vision, many women who complain of diplopia during eclampsia, their blindness is mostly reversible. It returns back. This blindness or blurring of vision that takes place during this episode of convulsion in eclampsia or preeclampsia is mainly because of cerebral edema. It is mainly because of cerebral edema, followed by a generalized vasospasm. Those inflammatory mediators are causing vasospasm, right? So those of you who were there with me talking about the pathophysiology of preeclampsia, eclampsia, these inflammatory mediators are causing endothelial damage. These inflammatory mediators are causing vasospasm and the various systems of the body. Generalized vasospasm, it is causing hypertension. Vasospasm at the level of the liver is causing liver ischemia, liver necrosis. That is responsible for the raised liver enzymes, right? This vasospasm can happen at the level of the retinal arteries, retinal circulation also, and lead to blurring of vision as a consequence of that, followed by retinal artery ischemia. Detachment can happen. I'm not denying detachment can happen. But detachment is something that is not commonly seen. They're asking you most likely finding. What is most commonly seen? Most commonly what is seen is a arteriolar spasm, retinal artery ischemia. So the arteries of the retinal arteries which are supplying the fundus, they undergo spasm. That is what you are going to see on the fundus. Retinal detachment can be seen, but it's something that's not common. Exudates and hemorrhage at the fundus, they can happen in chronic hypertensive cases. They can happen in chronic hypertensive women where there is hypertensive retinopathy. Exudates and hemorrhage are going to be a part of chronic hypertensive retinopathy features. Okay? And macular degeneration is something that will not frequently be seen. Okay? So the most common finding here would be arteriolar spasm. All right? Let's have a look at the next question. Now, which of the following statements regarding preeclampsia is true? Which of the following statements regarding preeclampsia is true? It's a totally preventable condition. Systolic rise of BP is more important than diastolic rise of BP. Eclampsia is always preceded by acute fulminating preeclampsia. And endothelial dysfunction is the central pathology. What is the true statement? Which is the true statement out of these four statements? Very good, Shataj, rightly answering. Endothelial dysfunction is the central pathology. Endothelial dysfunction is the central pathology. Preeclampsia is something that is not totally preventable. We can try to prevent it now. We can try to prevent it now in at-risk women by using low-dose aspirin throughout pregnancy. But even then, it is something that it is not totally preventable, unfortunately. Systolic rise of BP, rather than systolic rise of BP, it is diastolic rise of BP which is more important. Diastolic rise of BP is more important because there is peripheral vasoconstriction, right? There is arteriolar vasospasm, peripheral vasoconstriction, which increases the diastolic BP more. So the rise in diastolic BP is more important. Eclampsia is mostly preceded by an acute fulminating preeclampsia, but there have been times when women with mild preeclampsia have also developed eclampsia as a consequence, right? So always preceded by acute fulminating eclampsia is the wrong statement, right? Now, Neo, you have a doubt here. Is it good to reduce the BP to normal level in this patient because this pressure is maintaining the level of oxygen in the fetus? That is exactly what I told you in the very beginning, that we need to control the BP to avoid acute hypertensive complications, but we don't need to bring down the BP to 100 by 60, 100 by 70, 110 by 70. A good control would be somewhere between 130 by 140 and anywhere between 180 by 90 is good enough. That much control is okay. We don't want to bring it lower than that. No need to bring it too much low. Okay. Now let's see the next question. There's a 32-year-old primary Gravida at 39 weeks of gestational age, and she has a blood pressure reading of 150 by 100 mmHg, which is obtained during a routine visit. Her baseline blood pressure during the pregnancy, during the rest of the pregnancy prior to this 39-week period, has been 120 by 70. Okay, so she's been in the OPD visit, she's been a regular OPD visit, and her baseline blood pressure has been okay. But now suddenly at 39 weeks of gestation, her BP reading is 150 by 100. She denies any headache, visual change, nausea, vomiting, or abdominal pain. Her repeat BP is again high. You want to recheck the BP? It's again high, 160 by 90. You do a urine analysis, it's negative for protein. Which of the following is the most likely diagnosis based on the information provided to you? Based on the information provided to you, which of the following is the most likely diagnosis? Is it preeclampsia? Is it chronic hypertension? Is it eclampsia? Is it gestational hypertension? So, increase in BP, no proteinuria, no danger signs. According to this information provided, the diagnosis is likely to be gestational hypertension. High BP, no proteinuria, high BP, beyond 20 weeks of gestation, no proteinuria is what? It is gestational hypertension. Okay, now let's move on to the next question. There's a 32-year-old primary Gravida who comes for her first ANC visit at 12 weeks. Her BP is 160 by 100 mmHg. There is no history of hypertension pre-pregnancy. Repeat BP after 4 hours is again 150 by 90. There is no complaint of headache, pedal edema, blurring of vision. Urine albumin is 1+. What's the most likely diagnosis right now? What is the most likely diagnosis right now? She has high BP and she has less than 20 weeks of gestation. She is 12 weeks. No matter if she doesn't have hypertension pre-pregnancy, no matter if she has 1+ proteinuria, she is most likely to be a chronic hypertensive. She is most likely to be a chronic hypertensive. Don't get confused with urine albumin 1+. Preeclampsia mostly presents after 20 weeks of gestation, ideally. So, high BP beyond 20 weeks, that is preeclampsia. Couldn't she be a chronic hypertensive who doesn't know she's hypertensive? There's no history of hypertension pre-pregnancy. I mean, you and I, how often do we get our BPs checked? I could be hypertensive for all I know. I take so much stress in my life. But I've never gotten a BP checked on a regular routine basis. What if I'm not aware that I'm high BP? And somehow in pregnancy it has been picked up. It has been picked up when she got pregnant, because pregnancy is a time when BP is actually measured, isn't it? She has come for a ANC visit. That is when high BP was picked up. This 1+ proteinuria could be incidental. It could be a pre-existent chronic nephropathy. We don't know. So most likely diagnosis in this scenario right now is chronic hypertension, because she has high BP before 12 weeks of pregnancy. Now let me just summarize it for you. Maybe most of you are giving me multiple answers. Let me just summarize it all for you at one place. Let's say there is this woman, she got pregnant here. Let's say this is about 20 weeks. Let's say this is where she delivers. A timeline, I'm making a timeline. And let's say this is somewhere 12 weeks postpartum. Let's say this is 12 weeks postpartum, right? And this is all pre-pregnancy. Right? Now, any hypertension which is identified within the first 20 weeks of pregnancy, is chronic hypertension. Any hypertension which is identified beyond 20 weeks, mind you, and then the BP returns back to normal within 12 weeks postpartum. That is gestational hypertension. High BP beyond 20 weeks. Okay? High BP meaning BP more than 140 by 90 on multiple occasions. So high BP beyond 20 weeks of pregnancy. No proteinuria, right? then it is called as gestational hypertension, and the BP in case of gestational hypertension will come back to normal within 12 weeks of postpartum. The other situation you can ask me is now, what is preeclampsia? What is preeclampsia? Preeclampsia is the same. Preeclampsia is the same. High BP beyond 20 weeks, comes back to normal within 12 weeks postpartum. So during this time, beyond 20 weeks and within 12 weeks of postpartum, the BP should come back to normal. But the difference between gestational hypertension and preeclampsia is that in preeclampsia, there is either going to be proteinuria, there is either going to be evidence of proteinuria, and there are going to be a number of end organ changes. So proteinuria is not necessary for making the diagnosis of preeclampsia. If end organ changes are also present, it is called as preeclampsia. So whenever I identify a woman in pregnancy who's beyond 20 weeks with high BP, the next thing that I do is check for urine protein. Okay, the next thing that I also do simultaneously is check for end organ changes, because if any of these are present, I will call it as preeclampsia. Right? So what are the end organ changes that can be seen? Platelet count less than 1 lakh per mm cube. Right? A serum creatinine which is more than 1.1 milligram per deciliter. Raised liver enzymes, raised AST and ALT 2 times above the normal limits, right? There can be evidence of pulmonary edema. Right? There can be cerebral or visual symptoms. So if any of these end organ changes are present, I will call it as preeclampsia. So high BP beyond 20 weeks plus proteinuria, preeclampsia. High BP beyond 20 weeks, no proteinuria, but evidence of any of these end organ changes, it is still preeclampsia. So in gestational hypertension, it is the mildest form. It is high BP beyond 20 weeks, no proteinuria, and no end organ changes as well. The moment we start seeing proteinuria, the moment we start seeing end organ changes, it is preeclampsia. Mind you, women who are identified as gestational hypertension in pregnancy, about 50% of these women will actually progress to preeclampsia during the course of their pregnancy. 50% of these women are going to progress to preeclampsia. What does it mean? It means that clinically, the management of high BP doesn't necessarily change. I identify high BP, right? Once I've identified high BP, throughout the remainder of the pregnancy, I have to keep looking for evidence of proteinuria that can develop anytime, end organ changes that might develop anytime, because my goal is now to identify preeclampsia, right? So that is how it is going to be brought about. Right? Now, let's see another scenario. Now, let me summarize another thing for you. Let me summarize chronic hypertension for you. A woman who is already a known case of hypertension, gets pregnant, then that is chronic hypertension. In pregnancy. Right? A woman who is identified as hypertension in the first 20 weeks of pregnancy is chronic hypertension. All right, keep that in mind, because remember, there's a small snippet. What happens to BP normal in pregnancy? Normally in pregnancy, BP falls. Doesn't it? Normally in pregnancy, BP falls. And the falling of the BP is such that the fall in BP starts from early on in pregnancy, and then the BP reaches its lowest value somewhere around 24 to 26 weeks. BP starts falling early in pregnancy, and it reaches at a lowest point somewhere around 24 to 26 weeks, rises again, and then stabilizes at a level which is less than the pre-pregnancy level. That is the usual trend of BP in pregnancy. Now, for example, assume that there is a woman who has chronic hypertension. She will be having hypertension here. in the first 20 weeks of pregnancy, where BP should have fallen, but it is not falling for her. Why? Because she's chronic hypertensive. It's not falling for her. Why? Because she's chronic hypertensive. The next important thing is there can be a third scenario. I'll add a third scenario to it. Let's say, for example, there is a woman pre-pregnancy and her BP is 150 by 100. Her BP is 150 by 100. Okay, she's not too symptomatic with this high BP. Her BP ranges somewhere between 140 by 90 to 150 by 100 pre-pregnancy. She's still hypertensive by definition, but it has gone unidentified. She herself is not aware that I have hypertension pre-pregnancy. She goes on, becomes pregnant. During pregnancy, she comes for a first visit. In pregnancy, the BP naturally falls. Her BP also falls, and I measure it as 130 by 100. I measure it as 130 by 100. By definition, she is not 140 by 90. By definition, she is not more than 140 by 90. So here what will happen? Here what will happen? This hypertension might be missed in the first 20 weeks. Then it will again rise after 20 weeks. After 20 weeks, it will again rise and it will be falsely labeled as gestational hypertension. But what will change in this clinical scenario? Her BP will not normalize even after 12 weeks postpartum. So any BP which fails to normalize after 12 weeks postpartum is called chronic hypertension. So there can be situations where women are not aware pre-pregnancy that they are hypertensive. Their hypertension might also be missed in the first 20 weeks of pregnancy when the BP naturally falls. They might be identified as labeled as gestational hypertension or preeclampsia during the second half of their pregnancy, but their BP will not come back to normal within 12 weeks of postpartum. So after that point in time, they will be relabeled as chronic hypertension. This is all there is for, all the permutation combinations of identifications of hypertensive disorders have been discussed. All right. So any doubt here, you can ask me. If there's no doubt, I'll move ahead with the next question. Okay. Now let's see the next question. Let's have a look at the next question. There's a 25-year-old nulliparous woman and she is seen at 32 weeks of gestation. She's admitted to the labor room with a BP of 160 by 110, urine albumin 1+ by dipstick. There is no complaint right now of headache, blurring of vision, epigastric pain or decreased urine output. The NST is reactive. The baby is doing well. The non-stress test is reactive. Further management include all except. What will you not do? Send for urgent CBC, LFT, KFT, RFT renal function test. Start antihypertensive treatment. Immediate cesarean section if cervix is unfavorable, or steroid administration. Management includes all except. She is a woman. She is diagnosed at 32 weeks with a high BP of 160 by 110, urine albumin 1+. Right now, there are no impending signs and symptoms of eclampsia. Baby is doing well. Further management includes all except. Very good. No need for urgent cesarean section. She is preterm. She is less than 34 weeks. She is less than 34 weeks with severe high BP, likely severe preeclampsia, but I don't want to intervene immediately. Let me judge, let me try to stabilize, let me control the BP, start the antihypertensive treatment. Yes. Send for baseline investigations. Yes, I want to see the platelet count. I want to see the enzyme levels. I want to see the serum creatinine levels, right? So I will admit her. Keep her under observation. I will send for the urgent investigations because what do I want to do? I want to look for end organ features, whether they are present or not. End organ features, I want to look for them. So that is why these investigations need to be sent. These blood investigations need to be sent. Steroid administration should be given to the woman for pulmonary lung maturity of the fetus because she is less than 32 weeks. Why am I giving steroid administration? I'm giving steroid administration for fetal lung maturity in anticipation that what if this woman worsens? What if this woman worsens, her BP doesn't get controlled, she starts deteriorating, or at any point in time she develops eclampsia? I might have to terminate the pregnancy. So I'm looking ahead, I'm planning ahead, and that's why I'm giving steroid administration beforehand, because at any point in time she might need to be delivered. But right now there is no indication for going for an immediate cesarean section. Okay. Now, Emmanuel, I can see a comment there. Mechanism of action of magnesium sulfate. How does it inhibit calcium influx into the cell to bring about vasodilatation? Now, magnesium sulfate acts by various mechanisms. It has peripheral action. It also has central action. Now, magnesium sulfate has been seen to decrease the release of excitatory neurotransmitters in the brain. Okay, especially glutamate. Okay, so magnesium sulfate directly leads to decreased release of excitatory neurotransmitters in the brain like glutamate. It has been seen to potentiate the action of inhibitory neurotransmitters in the brain like adenosine and NMDA receptors. So it has a central action, which is the main mechanism of action in controlling convulsions. Okay, in controlling and preventing convulsions, magnesium sulfates mainly act by its direct action on the central nervous system, on the brain, by potentiating inhibitory neurotransmitters, okay, and inhibiting the release of excitatory neurotransmitters. So there's a central action, and then there, of course, there is a peripheral action as well, whereby it blocks the calcium channels. Okay. Now let's have a look at the next question. Now the same woman, we have admitted her. Please remember that all this monitoring will be after admission of the woman. So we have kept this woman admitted. Now this woman's BP ranges between 150 by 60 to 94 by 110 mmHg. Her urine albumin is 1+. Her platelet count is 1.1 lakh. Her serum creatinine is 1.2 milligram per deciliter. So the reports, the samples that you had sent, the reports have come back. You've checked the urine albumin, it's 1+. Platelet count is 1.1 lakh per mm cube. Serum creatinine is 1.2 milligram per deciliter. Liver function tests are normal. Cardiorespiratory examination is normal. There is no complaint of headache, blurring of vision, epigastric pain, or decreased urine output. The most important reason to give antihypertensive treatment in this particular woman is to decrease the incidence of I gave you the answer a couple of questions ago. That why is controlling BP so important? Because sudden high rise in BP can trigger maternal complications like stroke. It can cause placental abruption. So maternal complications like stroke and placental abruption are prevented by giving antihypertensive treatment. Even by giving antihypertensive treatment, you control the BP. Antihypertensive is you are controlling the BP. Does that mean you are getting rid of the pathophysiology? Does that mean you are getting rid of the inflammatory mediators? Does that mean that you are controlling the release of inflammatory mediators into the systemic circulation? Does that mean that those inflammatory mediators cannot cause cerebral edema? So eclampsia is not prevented by antihypertensive treatment. But yes, acute hypertensive complications like stroke and placental abruption is prevented. You will not be able to prevent IUGR, fetal death, or eclampsia by this antihypertensive treatment. The most important reason that you are going to use this antihypertensive treatment is to control maternal complications like stroke and placental abruption. IUGR that happens with preeclampsia or eclampsia is because of thrombosis, in the placental circulation, is because of thrombosis in the placental circulation, is because of narrowing of the spiral arterioles, So those inflammatory mediators which are released from the placenta, they cause placental inflammation also. They cause damage to the spiral arterioles also. They cause thrombosis in the spiral arterioles also. So the spiral arterioles become narrow. So this is your placenta here connecting to the baby, and that's your uterus. The spiral arterioles are the arteries which are perfusing the maternal part, perfusing the intervillous spaces. These are your spiral arterioles which are perfusing the placenta from the maternal side. If these arterioles are narrow, then blood flow coming into the placenta, the maternal blood flow coming to the placenta is compromised. If maternal blood flow coming to the placenta is compromised, from where will the baby extract all the oxygen and nutrients? Baby will be deprived of oxygen and nutrients which are brought by maternal blood into the placenta. So that triggers the IUGR, and fetal death potential can happen also in case of preeclampsia, eclampsia. So when you are treating the hypertension, you're not dealing with the pathophysiology. You're not eliminating the pathophysiology. What you're only doing is controlling maternal complications like stroke and placental abruption, which can arise because of sudden acute rise in BP. So keep that in mind as well. Now let's see the next question. All of the following drugs can be used to control her BP except. This is a woman who was at 32 weeks. We admitted her in the ward with severe preeclampsia. We can use all of these drugs to control her BP except nifedipine, labetalol, methyl dopa, or diuretics. We can use all except. What should we not use? Yes, nifedipine is a calcium channel blocker. It can be used. Your labetalol is what is now regarded as the drug of choice. It is considered a very good drug for control of BP. It can be used. Your methyl dopa is also a very good safe drug that can be used. But your diuretics are not used. We are not going to use diuretics to control her BP. Diuretics further contract the intravascular volume. These women already have a contracted intravascular volume. I don't want to contract it even further. Right? I don't want to decrease the plasma volume even further. So diuretics are not used for controlling the BP. Yes, but if there is pulmonary edema, then I will use diuretics to treat it. Otherwise, there is no need for using diuretics to control her BP. Very good, Ayush. Rightly said. Diuretics are going to worsen the hemo concentration. Very good. Now let's see the next question. There's a female with 35-week gestation, presents in emergency with complaint of headache, blurring of vision, BP is 170 by 110. How is the patient managed? Okay, Neo, meanwhile that you're figuring out the answer to the question, let me see this doubt with Neo. Which one will be the best antihypertensive? Labetalol is only short acting. So to maintain that 130 by 140 level, which would be the preferred choice? Labetalol is short acting when you give IV labetalol. Okay, when you give oral labetalol, it can be given, the dose has to be given, can be given three times daily, or maybe QID, 4 times daily dosages. Right? Nifedipine, much longer acting, can be given in the sustained release format. It can be given in the sustained release format, right? Once a day or even twice a day, right? And similarly, alpha methyl dopa can be given thrice daily or QID. So you'll have to give her round the clock oral drugs. To control her BP. Yes, but overall the drug of choice for better control, labetalol has been now considered to be the best. So labetalol is the best. What we do is we start with labetalol, and of course we have a limitation as to how much dose of labetalol we can give. So we can give max to max 1200 to 1600 milligrams of labetalol per day, and once we've reached that dosage, we add another drug. So it's not like we have to always use one drug. There are women who might require more than one drug to control their BP, right? So we can use labetalol plus nifedipine if labetalol alone doesn't work, or we can use methyldopa also. So we can use more than one drug also to control the BP, but we do start with labetalol first. Okay. Now, yes, now let's see the answer to the question here. B and C, that is what people have doubt about. B and C. I would say C is the answer. I would say C is the answer. Admit and observe, we all agree, has to be done. But she's already 35 weeks. Look at her BP. Severe preeclampsia. This is severe preeclampsia. Look at her BP. Look at her complaint of headache and blurring of vision, impending eclampsia. She might have a seizure right in front of you in no time. Impending eclampsia. Features of impending eclampsia. So we admit, we start magnesium sulfate. This is called as prophylactic magnesium sulfate. Prophylactic magnesium sulfate to prevent seizure. In a woman who is having severe preeclampsia with features of impending eclampsia, we give prophylactic magnesium sulfate to prevent seizure. Okay, so this is called as prophylactic magnesium sulfate. To control this high BP, we need antihypertensive also. And once there is severe preeclampsia and the pregnancy is beyond 34 weeks, there is no point in waiting. We have to terminate. Termination of pregnancy has to be done when there is severe preeclampsia and 34 weeks have been crossed. So that's why we are going to terminate the pregnancy. So Pragya is rightly saying magnesium sulfate has a neuroprotective role. Now, are you sure saying if the same woman was 32 to 33 weeks, add steroid, rest approach same? Very good. Yes, if she would have been less than 34 weeks, 32, 33, I would have at least wanted to continue the pregnancy for 2 more days so that I could cover these steroids. Let me go back to this situation here. This woman we had admitted at 32 weeks. This woman with a BP of 160 by 110, she was also preeclampsia. We admitted, we sent the investigations, we started the antihypertensive treatment, we gave the steroid administration. We're going to continue with that. And I'm going to keep her in the ward with daily observation. I will take twice daily rounds. I will monitor her. Okay, I will monitor her BP maybe 2 times a day, maybe 3 times a day, to check whether the BP is getting controlled or not. I will repeat her LFT, KFT and platelet count levels daily or maybe alternate day depending upon what are the baseline levels. I will keep a track of her daily NST also, keep a track for the baby also, monitor woman and monitor the mother and monitor the baby. If anything worsens during the course of my conservative management, I will give up the conservative management and terminate the pregnancy. Okay, if she starts having headache, if she starts worsening, her BP is not getting controlled, her platelet counts start to fall dramatically, her serum creatinine is worsening, right? So if end organ changes are worsening, or if placental abruption occurs, or if impending signs of eclampsia start coming, so daily, on a daily basis, this woman whom we had admitted with severe preeclampsia for observation shall be reviewed on a daily basis. Anytime that the mother or the baby are going to worsen, the conservative management will be given up and we'll have to terminate. Okay? Clear? Now, let's see the next question. A 36-year-old primary gravida with known chronic hypertension has come to the ANC clinic at 6 weeks of gestation. She is known chronic hypertensive. She's 36-year-old. Excuse me. Her BP is 140 by 90 and urine albumin right now is negative. She is counseled all of the following except baseline CBC, LFT, KFT is required. Baseline fundoscopy 24-hour protein estimation is done. Review of antihypertensive medication is done. Negative screening for preeclampsia can definitely exclude the risk of developing preeclampsia. So she is counseled all of the following except. Figure out the answer. Meanwhile, I'll take up Neo's doubt. If patient is in seizure and recurrent, one seizure, eclampsia, terminate irrespective of period of gestation. Yes, eclampsia terminate irrespective of period of gestation, right? Period. There is no conservative management waiting and watching in a case of eclampsia. Okay. Now, what is she counseled? Accept. Yes, very good. D is what we cannot tell her. A baseline CBC, LFT, KFT is required. She is non-chronic hypertensive. But I have to look for end organ changes. I need a baseline. I need a baseline. That is how I will compare it throughout the pregnancy. If I have a baseline, पहले ये था, अब ऐसा हो गया, right? So I need a baseline value so that I can compare future values with it. So I need to do those end organ changes. I need to have a baseline assessment of the fundus also. She is non-chronic hypertensive. She could have pre-existent retinal changes. She could have pre-existent retinopathy. I need to look for it, right? I need to go for a protein estimation also, one which is the proteinuria, to estimate for the kidney function, isn't it? Now, antihypertensive medication has to be reviewed. Maybe she is taking drugs. Maybe she is taking drugs to control that hypertension. Most of these non-pregnant people, which drugs are they using? These ACE inhibitors, these angiotensin receptor blockers, isn't it? These drugs, they are contraindicated. They are contraindicated in pregnancy. They are teratogenic. I can't use them. So I'll have to review what antihypertensive medication she is taking so that I can change the drugs. Right? So these drugs are contraindicated pregnancy. Your beta blockers like metoprolol, like beta blockers like your atenolol, they are also not used. Right? They predispose to IUGR. They have a side effect of causing IUGR. So they are also not used. They cause IUGR. These drugs, these are teratogenic. So her medication needs to be reviewed as to what she is taking. Negative screening for preeclampsia can definitely exclude, 100% exclude the risk of developing preeclampsia? No. Chronic hypertension can always progress to preeclampsia, right? Negative screening is not going to 100% eliminate the risk, right? So keep that in mind. Subhash, you're wanting to know if BP more than 170 by 100 with gestational age less than 34 with no impending signs of eclampsia, do we terminate after 24 hours of steroid? Gestational age less than 34. Less than 34 is how much less? Less than 34 is how much less? 33 is also less than 34. 32 is also less than 34. 30 is also less than 34. Isn't it? Right, isn't it? So less than 34 cannot be a general dictum for everybody. What I want you to understand is that we continue day after day, day after day, day after day. The longer we are able to prolong keeping the mother well and baby well is justified. All right. So if she is 28, 30, I want it to go more. I want to control more. I want to control a week, 2 weeks. That would be good, isn't it? There's no such for example 32 weeks. Example 32 weeks, then I will start the steroid. To complete the cover of steroid, 48 hours are needed. 2 days are needed. 2 days are needed to complete the course of steroids. So at least 2 days. Even after 2 days, I will reassess the situation. If the mother is doing well, the baby is doing well, your liver function tests, kidney function tests, and your platelet count is not worsening, there is no HELP syndrome, there is no complication, I can continue conservative management till 34 weeks. Okay, got it? So daily basis you have to review. If no such signs, can we prolong to 37 weeks? No. Your goal will be to prolong to 34 weeks. Your goal will be to prolong to 34 weeks. It is unlikely that we will be able to take a severe preeclampsia all the way up to 37 weeks. Okay, so it can vary from case to case basis. Okay, so one milestone at a time. One milestone at a time. Okay, so my goal at 32 will be, okay, I cross till 34. At least 34 are reached. Once 34 are reached, I will not be too overexcited that, okay, let me take till 37. But I will be wary that I want to take it from 34 to 35. You understand this situation here, guys. You understand this situation. It's a dilemma. If I've decided that I will go from 34 to 35, the dilemma is What if she goes into a complication? What if she worsens? Right? Then the problem is that if an eclampsia happens, if she worsens, there's a downward spiral. That's why in the case of severe preeclampsia, it's always wise that we go till 34 and terminate once 34 are crossed to be safe, and not be over anxious, not be over enthusiastic and try to take it till 37 weeks. Right? So treatment, yes, Gamacho is rightly substituting the word for me here, rightly helping me out here. Individualized treatment is usually individualized, but more or less, if there is severe preeclampsia and you've managed to take the pregnancy till 34 weeks, we terminate. Okay. If she's already more than 34 weeks, she's severe preeclampsia, there is no point being over anxious and just waiting, right? It's better to terminate. Severe preeclampsia, more than 34 weeks, terminate. All right, keep that in mind. Now let's have a look at this question. A 36-year-old woman with IVF conceived pregnancy, twin pregnancy, 12 weeks gestation, she's seen at 12 weeks of gestation. In her first pregnancy, which was 10 years back, she had developed preeclampsia. So history of preeclampsia is there in the third trimester, for which she had undergone a cesarean section at 37 weeks after failed induction of labor. Her current BP is 110/70. Ultrasound shows a healthy pregnancy. She is counseled all of the following except she has high risk of developing preeclampsia in this pregnancy. Normal uterine artery Doppler can safely rule out preeclampsia risk. Start aspirin 75 mg daily and continue throughout pregnancy. Salt restriction has no role in prevention. She is counseled all of the following except. Very good, Neo. Neo is the fastest there. Normal uterine artery can safely rule out preeclampsia risk. That is the wrong statement. Even after doing screening, the risk is not 100% eliminated. She is high risk. Why is she high risk? Why is she high risk? Age, twin pregnancy, history of eclampsia in the past. All these are making her high risk for developing preeclampsia. This is a high risk history. History is high risk. Preeclampsia has happened in the past, pregnancy can always recur. So she has high risk of developing preeclampsia in this pregnancy. This is true statement, right? Even if her screening is negative, she is still at high risk. We should start aspirin, low dose aspirin, and continue throughout pregnancy. That's true. Salt restriction has no role in prevention. That is also true. The only documented role in prevention of preeclampsia is by using aspirin. No other therapy has documented role in prevention of preeclampsia. Only documented evidences for aspirin, low dose aspirin. Keep that in mind. Salt restriction is good for chronic hypertension, I agree, but not for prevention of preeclampsia. No vitamin C, vitamin E, antioxidants, omega-3 fatty acids, all of these have been tried, but there is no evidence regarding their use. Calcium supplementation. Calcium supplementation has been found to be protective, or preventive, but not in all. Only in women who already have calcium deficiency. Only in women with calcium deficiency. Otherwise, routine calcium supplementation has not been documented to be preventive for the development of preeclampsia. Now, Saurav, when to start this aspirin? I will give you a new update regarding the FIGO screening. I have a video on this also on the YouTube, on this channel itself, but I'll still emphasize that the FIGO has recently come up with a screening for preeclampsia, saying that screening for preeclampsia should be offered to all women. All right, the screening consists of important factors like the history of high risk factors. We have to check the mean arterial pressure, mean arterial blood pressure. We can check the serum markers. The serum markers that are now included as far as this new screening protocol is considered is placental growth factor, and PAPE. These are the two factors that are considered. And uterine artery pulsatility index. This is seen on Doppler. And this is done between 11 to 13 plus 6 weeks. So according to the screening protocol, if high risk is identified, then the FIGO, the latest recommendations are to start low dose aspirin, from then itself. The screening results will be available. So the low dose aspirin needs to be started in the first trimester itself, right? Low dose aspirin. And this aspirin that is not low dose, the aspirin that the latest recommendation that are saying is 150 milligrams daily. 150 milligram daily is the latest recommendation, right? This is FIGO screening recommendation. This is the latest recommendation. People are moving from 75 milligram to 150 milligram daily dose of aspirin, started from the first trimester itself and to be continued throughout pregnancy. All right. The American guidelines, the ACOG guidelines, they are yet to adopt the FIGO screening guidelines, right? So if you read up the American guidelines, they'll still say that aspirin low dose 75 milligram to 81 milligram daily starting from the first trimester itself in women with high risk factors, right? These guidelines are yet to be adopted by the various associations like American or Royal College Association. So they are yet to be accepted. But yes, this is one recent update that has come. So it doesn't matter, you have to give aspirin. You can follow any of these guidelines. 75 milligram is good enough. 81 milligram is what is recommended by ACOG, but 81 milligram tablet is not available in the market. So that's why most of us tend to give 75. And after this latest FIGO screening guidelines, 150 milligram daily is what they are recommending to be given. Ayush, SFLT1, endoglin, etc. They are markers which are under investigation. They are markers which are under investigation. They have been found to be predictive, but they are not incorporated under any guidelines, right? So they are not routinely tested. Okay, they are markers that are under investigation, and therefore they are yet to be incorporated into some systemic guidelines. Okay. Now let's have a look at the last question of the day. Which of the following statements is not true about HELP syndrome? Which of the following statements is not true about HELP syndrome? Yes. BP may be normal. Nulliparity is not a risk factor. LDH is not used for making the diagnosis, or elevated conjugated bilirubin. Which of the following is not true about HELP syndrome? HELP syndrome is what? HELP syndrome is a severe form. It is a severe manifestation of preeclampsia where a constellation of things happen together. Basically, HELP syndrome is nothing but an acronym. HELP syndrome is an acronym for a situation where hemolysis, EL for elevated liver enzymes, and LP for low platelets, they occur together. So HELP syndrome is a mnemonic, is an acronym for hemolysis, elevated liver enzymes, and low platelets. So in a woman with preeclampsia or eclampsia, if she has hemolysis, evidence of hemolysis, if she has evidence of elevated liver enzyme, if she has low platelets, she said that she is having HELP syndrome. HELP syndrome, one has to terminate pregnancy. It is a severe syndrome. It is a severe manifestation. In HELP syndrome, you have to terminate the pregnancy irrespective of period of gestation. Please remember that. One situation where pregnancy was terminated irrespective, eclampsia. Placental abruption of the placenta. These are other indications of terminating the pregnancy irrespective of period of gestation. Another indication is HELP syndrome, right? So HELP syndrome is often preceded by high BP, but the BP may be normal in about 10 to 15% women. In about 10 to 15% BP may be normal. So this is true. Nulliparity is a risk factor for preeclampsia, and nulliparity is also a risk factor for HELLP syndrome. LDH can be used for making the diagnosis. LDH is going to be raised. It is going to be an evidence of hemolysis, isn't it? What is the evidence of hemolysis going to be? What is the evidence of hemolysis going to be? Peripheral smear. We can see the peripheral smear. On the peripheral smear, we can see schistocytes, Burr cells, evidence of hemolysis. We can check for the LDH. LDH is going to be raised in case of hemolysis. So LDH can be used for making the diagnosis true. Elevated conjugated bilirubin. Bilirubin can be raised. Elevated liver enzymes are there, ALT, AST. Those liver enzymes are raised to 2 times more than the upper limit, right? What about bilirubin? Bilirubin will be raised, but it is hemolytic. It is hemolytic. So what kind of bilirubin is raised in hemolysis? What kind of bilirubin is raised in hemolysis? Unconjugated. Unconjugated bilirubin, isn't it? So elevated conjugated bilirubin is the wrong thing, right? So you will have raised bilirubin, yes, but unconjugated bilirubin is going to be raised more, right? So that's why your answer is option number D. Now this becomes more not a it becomes more of a medicine question than an obstetric question, right? So medicine is all about this. All right, so a woman has to be seen as a patient also, right? You should not be forgetting when you're answering questions from obstetrics or from any other subject for matter. The crux is medicine. We should not be forgetting our medicine. We should not be forgetting our pathology. We should not be forgetting our basics, first year and second year, right? The basic subjects, the formative subjects, the building blocks, they should always be remembered, right? Okay. So that's been my time, guys. These are the set of questions that I had chosen for you to help you revise this vast topic, which is preeclampsia, eclampsia. It is a very, very important topic. It's a huge topic. There is a whole lot of pathophysiology that we go through and we consider, we read it, right? And it becomes easier to understand this topic when we have understood the basic pathophysiology, right? Now, Ayush, when am I planning to start the Next Plus course? Somewhere in the last week of October. In the last week of October, somewhere around 25 and 26, that is when I'm going to plan it. Okay? Chalo, guys. So, meanwhile, I will be posting special class sessions. I'll be posting special class sessions from day after tomorrow, and you can join me there. Tomorrow on YouTube, I'm going to take up another important topic for revision, MCQ based, on prenatal screening. On prenatal screening, not just Down syndrome screening, but all important aspects of prenatal screening. I'm going to discuss as much as I can, as much as I'm aware of. I will try to pass off that knowledge to you guys. And you can subscribe to the platform. You can use my code SHONALI and you can avail a 10% discount using this code. And I will see you next day, tomorrow, same time, 4 p.m. So bye-bye. Thank you and have a good day. Have a nice time and I'll see you tomorrow, same time, 4 p.m. on YouTube. Bye-bye, guys. Take care.